I think we've talked about this too. In order to, like, I think you asked me one time, like, what do I think is, what does somebody need to be good at, like, kind of seeing movement and good at movement? I mean, you got to, in my opinion, you have to have a really good knowledge of anatomy, because you have to be able to, if you know where stuff is and you watch movement, you're like, they're hinging excessively at C5 when they go into extension. They early lumbar flex when they're going to touch their toes. You're able to pick things out.
You're listening to the Restoring Human Movement podcast, where movement experts discuss the latest evidence-based practices to help you and your clients move with mastery. And now, your host, Dr. Sebastian Gonzalez.
Hey everybody, welcome. It's Dr. Sebastian Gonzalez, your host with the Restoring Human Movement podcast. Thanks for joining the movement. Today we have an extra special guest. We have a co-host, Dr. Cody Dimak.
How's it going, Seb?
Hey, good. So, Cody lost his microphone in the move, so now he's on a headset.
Yeah, it's not as clear, and I don't hear you as clear. You need all the help with your voice, so.
I'm going to make sure that on this video part, I'm going to make lots of hand gestures so you see that I'm still talking.
Yeah.
So then I thought we'll do co-host style a little bit today, and so everyone knows, I guess I'll introduce the podcast. So you haven't been listening to this podcast before. It's basically blending the line communication with doctor-patient and us two doctors kind of talking. Imagine we're having two beers, probably two West Coast IPAs from Green Flash. You can sponsor the podcast if you'd like. And there's a CPA next to us listening, and he's like, I don't know what the heck you guys are talking about. So we're trying to clean that up a little bit. In addition, when we're speaking to our patients, ideally we should have this nice general communication anyways. And so we'll try to make it like that today. But today is the part 5 of 5 series where we're talking with the presenters from the Pro Chiro Online CE platform, which Cody was nice to be on. And he went over a really cool section, which was introduction of loading with Flexion Intolerant spines. And so if you guys haven't seen it yet, there is a 10-minute snippet, which is completely free on Pro Chiro, which you guys can access and check it out. If you don't like it, then just spit it out. No big deal. And so we'll cover like a lot of the stuff that we went through today on that anyways, right?
Yep.
Cool. Before we start, since I know you love the introduction section, would you like to pose the question, since everyone wants to know about their host and co-host?
Pose the question.
Yeah, because you don't want me to do a rant. I know that.
Oh, no, yeah. Say so. Well, like you've been doing a good job of not, saying negative things, but just telling people a little bit about yourself. You've told them various stories. So, is there another story that you'd like to tell about yourself? A
good story. I can tell you that. I started gutting we have a 1930 hot rod, me and my dad. It's a 1934 Model A.
I've seen those pictures, yeah.
Yeah, and so we started gutting it. One of my patients is a welder, and now he's a good friend, and so we traded that out a little bit, and so we started taking the old wiring out of it, and I realized now that all of a sudden there's really good wiring, like the little nice braided cables and stuff, and so it's going to be pretty. And so that's my project for the next probably couple months, but...
That's how long is that going to take till you finish it?
Dude, I've had it since I was 15. Like,
all right.
I've had it. Yeah. So my mom, so she started setting up like...
A couple of months.
Yeah. Well, so it has an engine, it has a transmission, it has wheels, it has everything except for like the mechanics of putting it actually together.
Yeah.
So we're close. But my mom started doing like garage sale items like out there, and so she has tables just lined up, and because the car hasn't moved in 20 years, So now we started moving her crap around. Then you got to tell us a story about Mr. Dimak that everyone needs to know a little bit more about the Dimak.
Yeah. Well, let's see. Wow. There's so many. I don't know where to start.
Tell me the one about football that you remember as like the greatest moment, Al Bundy style, 4 touchdowns, 6 touchdowns in a single game.
I actually told this story the other day. It wasn't very glorious, but it was my freshman year of high school. I think it was probably like maybe the 3rd or 4th game of the season, and they put me in on kickoff team, and so I'm running down a kickoff team, and I got ear holed. So basically, I didn't see the guy coming, and he ear holed me, and my feet went over my head. I hit the back of my head on the turf and everything. But when I got up, I looked up. The guy with the ball was running like right at me, so I just laid him out. And that's the story of the first and last time I ever got ear holed. So.
Did you make sure that you knew where everyone else
again through college or nothing?
Is that why you said you have the wide linebacker vision? Is because you don't want to get a ear hold again?
That's part of it, right? Well, you need it, you know. You got to see the blocks coming down. So. Yeah.
Well, good. Now everyone knows you. So let's go into the topic then today, and we were talking the other day about just loading, and I think we had a podcast before, which was at number 122, I think, where we kind of introduced the idea of loading and how to use it for actually rehab, not just rehab, let's just say treatment, because I think people forget that actually you can use loading protocols to make people feel better than you could with manual tissue work, with adjusting, in these cases. And so we got a question on that one, which came from a listener. They said, what is loading? How would you describe loading to sum up that podcast?
I would say loading is, some people would say loading is only with like a type of implement, like a barbell, a kettlebell, dumbbell, a band, or something like that. But, and I think technically that's like the definition of loading. But even like the starting to introduce patterns, to me is kind of like a subcategory of loading, because now we're starting to load tissues or areas of the body that should be loading more. So in the case of like a flexion intolerant low back, generally people don't move well through the hips. Not everybody is like that, but most of the flexion intolerant issues are kind of a subcomponent of that, so to speak, would be poor loading through the hips. Mm-hmm. And so when if you start to deadlift or squat with those individuals, they're going to move excessively and not well, excessively through the low back and not that well through the hips. So loading would be with weight, technically.
Right.
But you still have to clean up some patterns before then. But you want to try and get to loading as fast as possible, and as safe as possible.
Well, that's one of the things with that when we went through. I forget the actual part of that workshop that we did, the loading process with that one guy. But one of the phrases he said, okay, we're gonna pattern this, and now we want to load it as fast as possible. Ideally in the same session, I'm assuming for you.
Yeah, especially if if you do some type of manual therapy too, right? So if you're doing some type of manual therapy in terms of like adjusting, manual mobilization, soft tissue, it's really good if you kind of try and we use the terms or the catchphrase to kind of seal that newfound mobility by load. And basically what you're doing is just telling the nervous system that, hey, I've given you this potential new range of motion. Here's some load. Now you have to control it. Mm-hmm. And the idea is that we get better carryover with those mobility solutions. But I mean, also in terms of patterning it before we load it, you can't just pattern something and hope it sticks around. It's the same principles. Like we're patterning something. Now let's load it to try and seal that in the brain, so to speak, make that normal. Yeah.
So for some reason, then I didn't hear in there that. So we talked about implements. The floor could be used as loading. Gravity could be used as loading.
Yeah. Well, you can start. We can get into the whole topic of wedging, which you've talked about extensively, I believe, either on the podcast or some YouTube stuff, right? So, basically putting stress on the body where it has to stop or resist or transfer motion would, I guess, theoretically be the definition of loading.
Mm-hmm. And again, I think to classify or just to frame stuff well for everybody, when we're talking about loading and the use of resistance training or whatever we might be using to make a change in somebody and make it improvements to how they feel, we're probably gonna, like, I tend to stay away from the concepts of manual therapy with adjusting and many types of manual therapy for that regard when I'm talking about it, because it's a whole different thing. And so I classify those a little bit more as like pain modification or pain modulation, which is appropriate at times, but it's not always needed. And I know that the interns that come in to see me, they're like, well, why'd you choose to load this one person and this other one you didn't? I'm like, well, that was an acute radiculopathy, and they could barely move. And so, I mean, if they were more of subacute or chronic, or like it tended to, like it was painful when they walked in, but when they sat down it's better, then there's fluctuations and there's maybe entry points, you know? So I think that I want to make sure to frame that for everybody is that, I mean, I believe that we can use loading with almost everybody that comes in, unless they're lit. Even then you can probably use it some, right?
Some type of variation of it, right? Yeah, absolutely.
Right. And it's all very scalable.
Well, I mean, yeah, absolutely. We had one instance today where a new patient walked in, and she obviously had a low back disc issue going on, the history, mechanism of injury, and everything. It just fit within that realm. So we just went straight to in-range loading, or starting to introduce in-range loading, which decreased leg pain drastically. And then she was walking around all stiff, and so I was like, okay, well, let's go for a walk. And just moving around, walking like that, you see the look on her face just kind of light up. You know, walking technically is load, right? So we're controlling how far you walk, how long you walk, is distance, is volume. And so it's not necessarily the load that one would think of in the weight room, but still you're putting stress on the body, or distributing stress on the body where it should go.
You know, the other day I was, or weeks ago, someone emailed me. There's this whole, I don't want to say algorithm, but it was like this big block of text about phases of when to deal with like tendons in a certain way, and then that, and this, and that. And I'm like, and they're like, do you agree with this? I'm like, yeah, it looks good, but you know, I feel like man steps on tack, man removes tack from foot, starts limping. 3 days later, he starts to need to eat, and he starts walking and slowly putting weight on foot. You know, it's like I don't know if we need to make this stuff super complicated, and I understand that you know the science says that these things happen during certain time periods, but I believe in like you're just looking at this elephant in the room thing. This person stepped on a tack like 3 years ago, and they have not introduced load into that foot. Like there's something kind of odd to me on that. And so you just start to introduce load in that foot, all of a sudden their back issues go away, right? Yeah. So I don't know, I just had the thought. I'm on a tangent in there. Sorry, man.
No, it's all good. I like it.
Yeah.
Tangente.
Is that a tangent in Spanish?
No.
Or is that just a type of fruit?
Tangent in the Restoring Human Movement.
So, when do you think then, let's go over a couple case maybe presentations, because I know that everyone's probably had seen, if they've gone through and taken that module, at least of yours. By the way, you can buy Cody's independently, in case you just want to learn more about loading. When do you think loading is appropriate with, say, an acute radiculopathy, numbness into the foot, positive SLRs, positive slumps test? Do you think there's any loading that's appropriate maybe in a person like this?
Yeah. I think the thing you have to clear is are we able to get into a hip hinge without increase in some of the peripheral symptoms? So I think you're not going to take the individual who's having radiculopathy symptoms and numbness and tingling radiating and into the leg and putting them through a hip hinge, and there's either their pain's getting worse or it hasn't changed, right? So we're not necessarily going to load like a deadlift or a hip hinge patterning in that scenario. I think the priority becomes, centralization and that at that standpoint. So trying to bring the symptoms away from the limb into the low back. And now when we start to, get more just low back pain, then I think the game changes a little bit. We can start being, if we start getting a little bit better control, lumbopelvic control in that hip hinge pattern, we can start talking about, truly loading that person.
Okay. And
I think it's more like a priority thing, It's like the leg pain is going to be a harmful hurt. The back pain is just going to be a hurt. right?
Yeah, so it's a good point. And definitely I think that the game does change a lot when you reduce the radicular symptoms, or at least they come above the knee and they become more especially transient controlled. There's a safety net in play. The person can control their symptoms. Then we can start introducing more.
And then does abdominal bracing decrease some of that symptoms when they go into that hip hinge?
Right.
You know what I mean? Or like, changing the angle, doing, using some analogies, or changing the environment to try and have movement come out, so to speak. And if the symptoms aren't increasing, then I mean, why not?
Right.
And obviously your repetition, sorry to keep interrupting you, your repetition range is going to be much lower. It's not going to be 3 sets of 10. It's not going to be 15 reps. You know what I mean? You may do 1 or 2 reps. See how we're doing. Reset here. Okay, let's reset.
Yeah, I think what you said there is important, is that just because it's not reducing their symptoms doesn't mean it's wrong. It's still okay. It's like a yellow flag in there. But if it increases their symptoms, then that's a no-go.
Yeah. And with that, it's either that's the wrong exercise for them at that point in time, or they may just not. They might not be doing exactly what you want them to do in that exercise. So, like for instance, I had again today I had a bunch of low back.
Wait, you worked today?
Lumbar disc. Yeah, I was all day today.
Bro, it's July 5th.
Yeah, man. Hey, man. School doesn't shut down. No, but we had a bunch of low back discs today, and one of them, he was kind of lit up. He was having symptoms down past the knee, and extension totally took it away. But he just could not move through the hips at all. So tried working some hip hinging, and it wasn't working out. So we audibled and we worked hip hinge a bit more cleverly. We put him in quadruped rocking and started rocking him, teaching him control of the pelvis as he starts to go into like the squat, so to speak, which is basically an unloaded hip hinge, and decrease. And then he actually felt really good with that. And so that was his homework. That turned into his hip hinging homework.
So let's explore that a little bit, because I think these are important things, and we'll circle back on this whole concept later. What else could you have picked in that? Because I know we're going to talk about toolbox here in a couple minutes, probably. What's another option?
I probably could have had him sit down on the edge of a table that's raised up fairly high, so he doesn't have to come out of a deep squat. And so we decrease the range of motion that he has to actually hip hinge into, because on the freestanding hip hinge, trying to lock his hands into his thighs and kind of anti-shrug, that McGill anti-shrug, to create some stiffness in the torso. Even with the abdominal brace, he could not hip hinge. It was all torso flexion. And so it didn't matter what cue I gave him. And I'm not going to sit here and try 500 different cues. After the third or fourth cue, and he's still not getting it, I'm changing the exercise. He's obviously uncomfortable, so he immediately went to unloaded. Now, I could potentially could have taken him from that point, and like I said, kind of move him to where he's sitting on the edge of a table or a raised chair, and start working on creating tension, and then standing up from that. But again, that's not a deep squat position. I mean, it's literally, maybe I don't even know how to explain it. It's just hardly any hip flexion at all, And so maybe you go, kind of, instead of working from the top down, kind of go bottom up a little bit from that.
Yeah, I think the sense you change. I know I do this too. And there's been a couple cases over the last year or so. I swear I look like a dog who got all of his toys out and just never cleaned up the floor, because I couldn't find, like, he kept finding, like, I clearly hip hinging helps this girl, but I can't figure out something that is getting her to feel better, or it keeps increasing symptoms. And so I kept on that track, but then long story short with this person is, so this lady didn't come back. And I think there's a good value in having a couple go-to exercises to really hammer that point in, and then knowing when to jump ship and scale back, because if they lose trust in you, then they're not coming back anyways. And so you jump ship on that one to get another one in, right? Yep.
No, I've had that happen to me too. I thought I was treating a lady, and I thought she was having in the exam she was having some glute pain She had positive slumps and positive SLR and Braggarts on the same side. And so we treated it like a low back disc, but also in the hip exam, we found that she was having some hip issues also. So we were actually doing some exercises for the hip itself, and then doing some core stuff. And she wasn't very compliant with her home care anyway, so she kind of fell off. And then she made it a point about 3 years later to show up in the office, tell me that I should check the hips because she ended up having hip replacement surgery. I was like, okay, yeah, you're right. You got it. Okay.
Was there degeneration actually in there, or like actually like bony like obstruction?
I didn't feel that. There was a little bit of it. I mean, she had decent internal rotation, you know, but there was it was hard infill on the internal rotation, but it wasn't like I start to internal rotate and at 5 degrees, I can't go any farther, you know?
Like it worked. It just wasn't working.
Yeah. It just wasn't correct. Yeah, exactly. It's a great way to put it.
It chose not to work at that moment.
I think to kind of drive home that point is, just because if you're not making the gains that you think you should be making, and especially the patient thinks that they should be making, you probably missed something in the assessment. Or there's other factors, right? It's more psychosocial factors and things that we need to consider in those individuals.
Mm-hmm. There was a student that I'll tell a story about this. I think it's relevant. He contacted me and he was asking about a shoulder person, and so they were treating him they were rehabbing him for a shoulder, and he basically told me stuff that he was doing, and it sounded good, you know, and I think logically, when we have someone who is supposed to respond to this shoulder rehab program, and if it's a good, well-rounded, deliberate program that is instructed well, there's no ifs, ands, or buts about it, they should respond. If they're not responding, you probably missed something in your exam. Yep. And lo and behold, they hadn't screened out really cervical involvement, and so I think that there's a very high success rate with using loading strategies and having a tool belt, which is that honestly makes a honest to God change with these people. Not just like, hey, this looks like it might work, maybe try this for 3 weeks. Like it shouldn't be that sheet of paper, try these things forever type of approach. Like it should make a definitive change. Right.
Yeah, no, the same thing. Student came to me asking me some tips for helping this patient with plantar fasciitis and same side low back pain. And I started asking some more questions and more thorough questions in terms of patient presentation, when does it hurt, et cetera. You know, the foot pain didn't really change. The back pain never really was, it wasn't as intense as the foot pain, and the foot pain was never really as intense as the back pain. So I was like, have you done any extension and range extension for the low back and see if the foot pain, lessens? And they're like, no. So we did that, and then lo and behold, the foot pain went away. So it wasn't so much as two separate issues as you got to clear upstream. And we showed him some cool stuff from Shacklock's Neurodynamics. We did the 3 different biases and straight leg raise, and sure enough, like some of the they made a difference in what she felt. Right, so it's really interesting.
Yeah. I don't know if I told you, I had a case recently that I think getting on topic, but I had a case. It was a heel pain case. Did I tell you this one? And so,
I don't think so.
So she rolled in and she has heel pain that heels, Achilles, kind of like inner arch pain it's been a while. So there's a stairwell by my office, and so I was like, how can you? I really didn't light her up too much on exam, much at all, and so actually I take it back. She had a positive SLR, and so she goes out in the stairwell, and so she says, I feel it when I stretch my calf. And so she's looking down at it, and I say, look up. And she's like, oh, went away. And so we did openers and contralateral sliders on her, and that cleared it all up after about 2 weeks. But
isn't that funny?
Yeah, that was a fun one.
Well, that's one thing that you start to learn too when you start to dive into like courses like Michael Shacklock's and Philip Snell's courses. You if you're not looking for, before, I'll tell you, Shacklock's course is an absolute game changer, period. So many pesky things that you have trouble, working on like medial epicondylitis, lateral epicondylitis, like that are not clearing up with, your what usually clears it up with shoulder cases, heel pain stuff, all that, those neurodynamic tests, man. I mean, you nail it every time.
Yeah.
And just, when in doubt, just test for neuro. That's what I tell the students over at Parker. I say, look, when you're formulating a differential diagnosis, consider two things. After you've ruled out red flags, right? Consider what are the tissues in that area that could be really irritated, and what could be referring there, whether that's nerve root or peripheral nerve.
Mm-hmm.
And if you think about it and you rule it out, you'll never miss it. You know what I mean?
Yeah, I totally agree. I think that it's funny. We come from, we have the chiropractic profession that we're all based upon nerve stuff, and then we forget about how much nerve stuff can create a thing in this, But I know it's a little bit of a different way than when we started out with our profession, probably. But either way, I think it's important. Now, I think this might be a cool game then. Let's do this. So, me and Cody actually, he flew out and we recorded a module 2, which won't be released by the time this podcast goes on, but it's on upper extremity or upper quarter loading. And I think we did a better job this time, and he had a good idea of creating a toolbox. And just like how you kind of heard him earlier with, I asked, what else could you have used? There is no one single magic exercise, but there are ones that when you're trying to do something and get a certain effect out of the person, you can do it many different ways. And so in this one, he recorded a lot of tools for that. But why don't we play a game? Why don't we go through a case presentation, and then we'll dissect this different ways and see what else might work. We'll try lower extremity stuff.
Okay.
Okay. You want me to make one up first?
Sure. Yeah.
Okay. Let's go with medial knee pain while running, no trauma. There's a valgus collapse in the foot or a loss of. It's dynamic though, open chain. You can kind of see, like they both look symmetrical. Mm-hmm. No real low back pain, but it's in the inner part, right under the patella area, and on and off for years.
Tempo.
What's that?
Tempo.
What's my tempo?
Their speed. No, their speed. Running. That's what I would probably look at first.
Okay.
Honestly.
So we're gonna go with a 12-minute mile.
So slow. Can they run faster?
I mean, they can if they're chased by a lion.
But honestly, if I'm, aside from, we can go biomechanics, and we can look at like glute stuff and foot, kind of glute hip or hip, knee, foot exercises, which we'll dive into here in a second. I guess we'll get into it. One of the biggest things is, I think actually you and Greg Lehman talked about it.
Yeah, this was actually not the same case. I just made one up on a fly, but
yeah, it was kind of funny. Is honestly every time I have a patient who has pain running, or record them running, specifically try and get that side view right when they're crossing the camera, so we can see where what's the where's the foot strike, and just observing the speed, right? Mm-hmm. And can they run faster? Like I think you said can you run faster? But when we're introducing people back into distance running, we actually have them train sprint intervals. If the sprinting doesn't hurt, then we're going to start try and build up fitness and to the point to where we can actually have a faster tempo of running. So we're not kind of slothing down the pavement or along the trail, So, but kind of rewinding a little bit.
You don't want to go straight to being a running coach then, huh?
No, we're not going to get into sprint mechanics stuff. So,
I agree with that though. So.
Yeah, I actually teach runners how to try and get them how to sprint. Try and teach them. I actually do sprinting drills with them. A lot of wall marches, a lot of various wall drills for sprinting, and then start introducing truly like just running, sprinting.
Well, I think we can jump into this then. Why do you go that route? Well, actually, do you give them anything else first? And if not, let's focus on this. And why do you give them a wall marching?
The wall marching because it teaches a more forward lean and kind of and triple extension through the hip, knee, and the ankle, or well, not, yeah. So
okay, I thought you were going to say I was looking to improve foot loading through dorsiflexion.
No, I'm not really worried about. I'm going to harp on the.
Sorry, I was thinking toe.
Oh, okay, yeah, through great toe extension. No, it's part of it, right? So you're getting extension, but that's a part of the assessment too. And so that goes back to like some of maybe the biomechanical things that we're working on. We can try and go down these various rabbit holes of what came first, the chicken or the egg, in terms of is the foot pronating because of poor glute function, or vice versa, or is it because we don't have good transverse arch activity in the foot? Is that because we don't have great toe extension? Blah, blah, blah. It doesn't matter. You're going to have to address everything, almost all of it anyway, right? And so, we'll start to get, we look at hip issues. We look at just kind of foot loading. We look at, toe mobility, just kind of general foot activity. Do they have a dead foot? Do we have to kind of wake up, maybe give them some foot homework and whatnot? There's a lot of pieces of the puzzle. And everybody's kind of different. That's why I guess you got to know to look for the stuff too, instead of just giving quad sets and straight leg raises to try and activate VMO. Yeah,
so that's actually I was going to ask. So you didn't go to a knee specific exercise?
Usually if there's pain in the knee, it's not the knee's problem. Usually,
right?
Especially if we're going valgus collapse. You look at Chris Power's work. DPT out of LA, he's like the Stuart McGill of knees, right? And so his work has shown is, a lot when the foot's in contact with the ground, usually if the knee's going to the valgus, the femur is going into flexion, adduction, and internal rotation. The exact opposite of that is the glute max function, extension, abduction, external rotation. So really the foot's in contact with the ground. It's the eccentric control of glute max that is potentially not allowing that femur to stay in a relatively, there's no one good position, but a good position that, if that pain is from valgus collapse. We don't even know if it is from valgus collapse, right?
Mm-hmm.
So, but the thing is like, you have to have good foot loading too in order for glute max to be as efficient as you would like it to be.
Right. And so for this person, then go ahead.
No, so but we could get into all this biomechanical stuff too, and we're not going to bog the patient down with telling them all this stuff. We need to know this stuff as practitioners, but we're not going to tell the patient and vomit information at them, right? You just say, hey, we're going to do these exercises to kind of help your sprinting form or help you improve your sprinting or your running, right? And so they may ask the question, why? You don't want to necessarily bog them down with all this potentially things that they might perceive as pathological, but you need to know this as a practitioner.
Mm-hmm. And so let's just say with that person, I noticed then. So we didn't stick knee focal on that, although loading of the knee. And
were though, in exercises when you are loading the glute and hip and everything, and foot, you're actually loading the knee as well.
Right.
But it's not isolation, right? It's isolation through integration. So we may have like a quad focus, we may have a hip focus, but we're integrating in some type of pattern or position that loads multiple joints.
Well, and so you didn't go through isolation of the glute med nor the foot.
Correct.
So you challenge the entire limb or the system.
And that's the goal, right? Anything that, and Craig Levinson talks about this all the time, is you want to try and find the hardest thing they can do well. And usually they can do more than a clamshell.
Mm-hmm. And so just scaling back, because I know that I'm trying to pick this apart for listeners, is that when is a clamshell appropriate?
One time that is very appropriate is if you have some legitimate neurological nerve root weakness and there's atrophy and there's hardly any activity. Let's say you have 80-year-old grandmother who's got some serious stenosis and they may have had surgery or they're on their way to surgery and there's just no glute activity at all. I think that's very appropriate. Maybe coming out of hip surgery. That's probably an appropriate time as well. But if somebody, they're relatively healthy, they're pretty active already. They run, they maybe play softball, they play pickup basketball. We're probably not going to start them on something that's that low on the movement totem pole. Mm-hmm. There's other exercises we can do to facilitate the musculature that may integrate other muscles into it as well.
Right. So I agree. I just want to play devil's advocate with it.
No, I like it.
Because I think so. Something
bring it on, devil.
we talk about this off air is that I think it is important to realize and keep hammering this home that corrective exercise is not the end all. Like, they should not be doing this forever. They shouldn't be doing clamshells or bird dogs or isolated stuff forever, or even wall marching. Like, the goal is to get them into some type of resistance training to simulate, in my opinion, life. Because load is life, and they're going to be doing it anyways, so you might as well just get them really good at it.
That's it.
Yeah. And so, in your opinion, or what you've seen from docs at a school, I can tell you my opinion. I'll tell you my opinion first. Is they're familiar with the exercise, some of the corrective exercises, but they don't know when to use them. They don't know how to change that. Let's just say if we gave someone a clamshell, they don't know how. They're like, this person has back pain with a clamshell, so I'm not going to do clamshell. It's like, well, maybe you change. Like, can you have them stiffen up their body a little bit? Oh, the back pain went away, and so I think they need to better learn how to implement these movements or loads with people with the problems, rather than just ditching them completely, because they might be an easy win there. And they just have to have a keen eye for it. But in my experience, a lot of them don't have that, which I'm not blaming them for it, but neither do a lot of seasoned docs either.
It's true.
And so we default to our passive care.
Absolutely. Well, it's easy, right? Passive care is easy. Like doing soft tissues, it's it's not easy on the body, right? But like literally, like, I'm not saying everybody does this, or I'm not saying that most people do this, but like it's really easy for you to start doing soft tissue and you just kind of blank out. You know what I mean? You just go totally, like, mind is like elsewhere. You're thinking about what you're gonna have for dinner, right? But you can do that doing soft tissue. You can't do that during exercise, or coaching a movement, or looking at evaluating movement, or assessing movement rather. Right? You just can't do it. Yeah. You have to be on all the time, and that's why you have in your practice, if you have a day that's like 12 patients, that's a long day. And that is a.
Well, I hope they're just openers and sliders. That's it.
You're exactly. More passive care. No, but I mean, I think we've talked about this too. In order to, like, I think you asked me one time. You asked me, like, what do I think is what does somebody need to be good at, like, kind of seeing movement and good at movement? I mean, you got to, in my opinion, you have to have a really good knowledge of anatomy, because you have to be able to, if you know where stuff is and you watch movement, you're like, they're hinging excessively at C5 when they go into extension. They early lumbar flex when they're going to touch their toes. You're able to pick things out. And so repeatedly, I'll ask the student, did you see that? It was like, to me, it's glaringly obvious. And they're like, whoa, what? They're like, I don't see it. It's because they don't have the repetition, right? And I think that, getting the clinic, and that's why I hammer them, like, look, every time they come in, do part of the movement assessment. Do it. The more reps you can get, the more you're going to see, the better you're going to be at seeing things. When you start to do corrective exercises, if they start to have pain with the exercise, you're not going to totally audible immediately from that. But you'll probably be able to give them one focus or one cue on a thing and completely change the outcome to that exercise.
Right. Yeah. It's really, I've noticed that, so the interns that are with me right now, like I told them that I feel like my responsibility to them is that they walk away with, like, I don't want to say all the tools in the toolbox, but like the ones that tend to work for certain cases, and they need to be really good at coaching the person out of the symptom. Yeah. And it's challenging because people, like, even when we're working, like when I'm working with them, it's like, okay, you got them to feel the area that needed to be loaded, but that person didn't have an ambient symptom. And then when you get one where it's like, oh, my other knee hurts with this, you're like, oh, okay, I don't know what to do now. Like they can. I remember this one guy came in one time. I didn't tell you about this guy. He came one time. He had the oddest responses to orthopedic exams. Like I would work with his knees, like my left pinky hurts, and I'm like, oh, I don't know, I don't know how they're related. I don't even know how to take that. But if you do that with a loaded exercise, it's like, oh, I'm just going to ditch this thing. If you don't know what you're looking to improve in their position or movement. Yeah,
it's kind of like when you're doing slumps on somebody, and when you passively extend their knee, the bilateral pinkies start getting numb, and then when you put the knee down, it goes away. Oh, what?
Yeah. Or the first time you find a downward sliding dysfunction, you're like, it got better?
Yeah. Wait, what?
Yeah. So
that was good.
What's another case you want to go over? We'll stick lower extremity.
Yeah. So I think, so what about a person who comes in with maybe they have Achilles pain, not necessarily heel pain, like kind of like the case that you have before. What if they do have legitimate, like kind of like Achilles tendon, almost up the insertion, but along the Achilles tendon?
Okay.
Specifically the medial portion.
Ruined medial. I'd screen neuro out first, probably. So I'd check slumps, SLR, all that jazz, and see. I probably had I do a bad job of this, I think, now, but I think, oh man, this is going to be so easy. Let's just do openers. And sometimes it goes away. But I'd probably ask the person if I couldn't find much on the exams and they're just very high function. I'd say, look, show me what hurts. Sometimes they'll show you the weirdest stuff, and I tell them, look, you can pick anything except for a stretch.
Yeah.
And so let's just say they picked, what do you want to pick, since you made this case up?
Let's say walking upstairs.
Walking upstairs. Okay. So I'd take them to the stairwell, let them pick, and say, look, just remember how this feels, okay? We're going to come back and test this again. And so usually I'll go through in my exam, I'll go through intersegmental flexion, extension of the spine, rotation, squatting, and usually like some type of star excursion test. Y test, I think, is what FMS started taking it as. And so I'll just look at a glaring to see with that. If I find anything on neuro, if I see them offloading a certain side, I'll just pick like say they're loading. It's not uncommon to be loading on the side of complaint.
Totally.
And so I'll just challenge the other side and then just see. And so usually what I'll do for introduction of loading onto the other side, let's say, or by the way, they could be offloading on that side, but if it's an inappropriate amount of time for offloading, like at tack analogy, I'll still load it. But if it makes sense where they stepped on a tack the other day, I'm not going to force them to. So usually I'll go through a low diagonal sit first.
On what side?
Whatever side they're offloading. And so I don't.
And by offloading, because there's some students out there that don't know what you mean by offloading.
You step on a tack, you take load off that foot. And so I think the body's protective mechanism of protecting that area that has like the tack is to take weight off. And we don't teach people to limp; they just limp. And
what if you put this patient, let's say it's their right Achilles that's bothering them. What if you put them through a bilateral squat and they shift into the right?
So that they're not giving their body, or they're not giving that tendon probably the proper healing time, or the load has exceeded the repair time. Yep. And so I would give them the theory of there's a possibility that so your body's showing me what it's doing as a habit currently. And so if I were to punch you a bunch in the arm, at some point, like real light punches, at some point you're going to bruise up. And I'm going to keep punching you, right? And it's not really fair to say I need to address that area directly. I can just stop the punching. And in this case, we just offload the area. And I'm not saying bed rest. I give them more of a loading-based correction. In this case, low diagonal sit, single leg deadlifting, opposite side bias first probably, and then go retest. And if they feel better, then I stick to that. And then usually I'll tell them like, look, this 1 or 2 is your exercise that I want you to do as a medication. I give them the example of like a antibiotic, since they're all pretty familiar with that. I'm going to give you 1 antibiotic pill today, but you have to take the rest of them for the next 5 days, and you got to do it yourself. and the cumulative dosage should have an overall effect. If it doesn't have the effect, I picked the wrong medication for you, or you didn't take it. And so we just kind of see, and we're collecting data points with that. And so I'll just give them a couple of those things, and if it produces I like 50% change on whatever they picked or more. Yeah. But if they say 30, same. I stick with it. Yeah. And so that's probably where I'd take that. But other options of exercises would be, I've done a hydrant on that. Mm-hmm. I've done
and quadruped. Is that what you're talking about?
A quadruped hydrant. Yeah, I've done that. I've done a single leg bridge, and I'll almost sit on them, you know. Mm-hmm. Sometimes I call it a shitty clamshell, where I put them into like a clamshell position, but then make them pop off the floor, rotate them in a little bit so they have internal rotation. Yep. Okay. Because sometimes with...
They kind of like off of oblique sit or low diagonal sit?
Yeah, sometimes they just can't let that back leg go, and so I'll put it in front, you know. Mm-hmm. And so lots of options of things to try, or rotational squat works, you know, totally. but I don't want to teach it right now.
That's hard, yeah.
So I think I can get a response out of all of these some way or another, and it won't take any more than 5 minutes, and that person will feel better, and I will not do a tissue work approach on that person if I find that's a productive outcome.
Right. And I think, so, you know, we've talked about this plenty, but that, like you said, there's probably some new listeners on here. You know, what's the significance of that? If you taking that exercise approach and within 5 minutes, potentially, you know, attempting to offload the stress in that area and allowing, giving them an exercise to take home and for the time being, avoid soft tissue work.
What's the point of avoiding the soft tissue for that time? Well, you know, I always tell people that, like, because usually they have a past history of things they've tried. And I mean, really rarely you're going to get somebody who's not tried a thing. And I say, what have you tried? And they said, well, I tried tissue work and stretching and adjustments and icing and resting and
lacrosse ball.
They tried all that stuff. And I say, look, I'll be honest with you. If it was going to work, it would have worked. Mm-hmm. But if it didn't work, let's try something different. And like, I'm not opposed to, like, I'm like, look, if you came in for tissue work, like, I will do it if needed, but let's try this first. You know, allow me to do my job. And I'm like, if this was gonna work, I explain this with people with nerve stuff. I'm like, or if you do like an opener and their leg pain, or so their leg pain goes away or their foot pain goes away, and they're concerned it's an ankle in this case. And I said, look, if this was an Achilles tendonitis, it was like swollen, boggy, all that stuff, this wouldn't work.
Right.
But it did.
Right.
So work with me on this, you know. But that's the reason. I don't want to muddy the water with doing more, you know.
More of the same.
Mm-hmm.
No, yeah, I totally agree.
So in that then same example, what are some other tools that you could have used?
In this, the Achilles?
They're loading the side of complaint of the Achilles.
Yeah, well, I always look at the contralateral hip first. And that's the easiest. It's the kind of low-lying fruit, right? So if they have some, you know, poor internal rotation on that side, I'm attacking that first. Same with like knee. Like if somebody has knee pain, hip pain, low back pain, but they're shifting into the side of discomfort, then I'm going to look at the contralateral hip. And usually it's the hip, and if it's not the hip, it's probably foot and ankle or somewhere along that other side. To me, it's just the brain telling their body that they can't, you know, if their right side hurts, even though the right side hurts to move into, which they probably don't move into it because they don't move, right? Because every time they move, it hurts. Mm-hmm. You know what I mean? So we're looking at the other side, the contralateral limb, and then 9 times out of 10, you're going to find something on that side that doesn't hurt, that's not moving as well as it should. And by, you know, whether that we clear that up with manual therapy or we clear that up, usually it's with an exercise and then load that and then retest. And like you say, usually that clears up the side that's painful.
Yeah. And so let me clean that up a little bit here, I think. So we're gonna load the opposite side with some type of, you'd pick a oblique sit, probably, right?
Right.
And
for
then
internal rotation issues in the hip, yeah, it's a go-to like a low diagonal sit.
Okay, so we retest that walking upstairs. They feel better. You immediately follow it up by getting out of the corrective exercise, and you would load them in now a a foot on ground movement.
Yeah, it depends on their balance, right? So I'm gonna do an exercise to try and stress that internal rotation and flexion of the hip. So it may be something as simple as like a kind of just like a split stance, working on a sprinter split stance, not like a split squat, but more of a push off split stance, kind of like the Koichi's H step pattern, I believe he called it.
H step? Is that like
step pattern?
Is that a popular dance down there in Texas?
No, it was Tokyo. But getting them to load into the hip, and specifically flexion and having the almost like a single leg pattern, so the femur is rather close to midline, and then we could maybe potentially progress them to like a single leg deadlift if they have the balance, or a variation of a single leg deadlift, even if it's like a door jam. They're holding on to the door jam or holding on to a squat rig or something like that, and they're just grooving that single leg pattern, and there's no pain. Maybe we can, with some support, go into a hip airplane. Maybe. I mean, we have all these options, right? And there's the options are endless.
Probably an important part. I don't know. Someone's probably thinking of something this side is, well, what if they have hip impingement pain on that side?
Yeah, and so that's where the low diagonal sit comes in. There's different things you can do in that position, specifically with traction of the down pelvis. And so even though we're rotating the pelvis on top of the femur into relative hip internal rotation, the traction actually will decrease and desensitize occasionally some of that sensitivity in the front of the hip. Now, we're not trying to go through bone. That's not the idea. But, even with bony impingement, you can, potentially you can desensitize what they feel as pain there by cleverly loading them.
Mm-hmm. Yeah, I can test it. I can be a testament to that. It does work. And if anyone's struggling with treating people with hip impingement, I think it's a driver for symptoms. Like it's not too hard. It's really not too hard. You just have to have the tools, the appropriate tools, loading tools, if they're not responding to passive care. But also too on that, so hip impingement, it clears out partially with slight posterior tilt of the pelvis. They found that on radiological studies. So you can cue them into probably a slight posterior tilt if they're not opposed to it.
Well, I think in particular when they're in split stance, right? And so, like, if you're worried about posterior tilting, let's say they have the patient has like some low back disc issues, and flexion is the thing that picks their scab. You might not want to do like a bilateral posterior pelvic tilt, right? But what if you go one side, like in a kind of half kneeling stance, and start doing like a pelvic tilt or something like that, a slight pelvic tilt, and closing, opening up a little bit more room for hip flexion. I don't know. I
imagine you kind of doing that, like when you're just like when the coach was talking to you, you just half kneeling, doing pelvic tilt. Yes, coach. Like when you do these.
Maybe you guys did that in Eagle Scouts. I don't know. Never did that in football.
Take a knee, boys. Let's do some pelvic tilts.
Eagle Scout thing. I don't know.
No, Eagle Scouts, like, no. I don't think there was no huddle. If we did have this, it was in Boy Scouts, you had this huddle up circle, like, say, the Scout Law.
Yeah.
That was that exit. In baseball, you had to take a knee, and the coach would take, like, our coach anyways, like, he took his foot, and he would just go swipe on the dirt, back and forth, and look down at his foot. Yeah, as he's just reaming us.
Smoothing it out, yeah.
He's smoothing the dirt, but he's over the line, too, so he's just smoothing the line.
He's like spitting his chew out, and he's kind of like rolling dirt over his spit.
Yeah. He's basically just rolling that spit, spit globule in the brick dust.
Yeah. So
as we start to close this one out, then, since we're about 50 something minutes in, is there? I feel like it's every time we talk on this podcast, it's going down the route of loading, and I don't know any other way to say this, but maybe you'll make it nicer. Is that I think that people really, practitioners of many different types, and I sucked at it years ago. I really did suck at it. We need to get better. Like, we're really good at passive care, loading and corrective strategies, and getting them out of the corrective strategy is very lacking in our profession. And just because you lift a barbell doesn't mean that you know how to cue these things on people either. They're different, and they're different animals.
Totally different, yeah. Yeah, no, I think you said that nicely. I don't think that was bad. But I agree 100%, though. I think if we can improve as a profession in terms of chiropractic profession, and other professions, like you said, can improve in this as well. It's knowing when to apply load, and not being afraid to, and knowing when to pull what card, when to apply this exercise, what should I follow up before this? What should I pick for this? Right. And you want to go what's the best risk reward, and the exercise and the thing that can give you you can use minimal effective dosage on and have the biggest bang for your buck.
I agree. There's I think one barrier for people when they're thinking about adding a corrective or active component in their practice is they think it's going to take too long. It doesn't take long at all.
No, it doesn't.
Like we can make we'll see what you say. I can make a definitive change on somebody with a corrective strategy, with a loading strategy, with the even like old symptoms. I'm like, let's leave radiculopathies out of it. As long as they're willing to, I can make a definitive change in less than 5 minutes.
If we've done our due diligence on our assessment, yes.
Right. Yeah, we'll take the exam and history out of that.
Yeah, right. No, I mean, if we've done what we're supposed to do on our history and our examination, then we're going to be really, really pinpoint on what we're going to attack in terms of exercise. And I agree, we can make sometimes even less, right? I mean, sometimes you might do 1 or 2 reps of something, and then completely and make a huge change.
Yeah.
One student was having his patient, when they would go to do multi-segmental flexion and extension, especially multi-segmental flexion, he had some right hip pain. And I said, okay, anterior hip pain. I said, okay, well, let's do this here. I said, where was the pelvic shift? He said, to the right. I said, okay, I'll tell you what. Let's load. I want you to do left side bridge, just left side. 80% ready to proceed exertion, 10 seconds on, 1 to 2 seconds off. And I mean 80%. I want him to barely have anything in the tank. He goes, okay. And he did it, and pain completely went away. It didn't take many reps. It was like maybe 6 or 7 reps. But that alone is, it's under like 3 minutes. You know what I mean? And so then he retested toe touch, and it was completely gone. Felt great. Mm-hmm. The shift was gone too. So now the brain perceives that it thinks it can load the left side, and it does load the left side more, and offloads that right hip, so to speak, kind of like how we were talking earlier. And so our exercise choice and that was a core stiffener.
Yep. Yep. And that's just, now the person does that as homework, and we have to reverse engineer a process. Yeah. Yep. Adaptive process.
That's it. And just manage load through tissue. We do that, like you said, by offloading, but also, and this is something that Tim Gabbett talks about in terms of, we need to know when the patients come in, we need to know kind of what they're coming in with. We need to know where they want to be, what are their goals, and where does their capacity need to be, so to speak. And we need to know how much time we have to get there. Because if we have somebody who wants to run a marathon, the longest they've ever ran before was 5K, and the marathon's in 4 weeks.
That's usually when they come in,
and they don't strength train. So it's like, I don't know if we're going to get there. But then again, you might have somebody walk through the door, and their current capacity is either really close or maybe even right at what's required, and for their goals, and they have 12 weeks before they have to before they compete. I mean, that's like the golden goose right there. That's the optimal scenario. You hardly have to do anything. You just kind of give them a little bit, and it pushes them to where they need to be. So you got to consider all that stuff too when we start talking about exercise choice, the biggest bang for your buck, and are things actually realistic?
Mm-hmm. Yeah, I agree. That's the I guess the art of coaching loading.
Also, there you go. Also, kind of have a thing for loading too, because you can, we can, do our manual therapy, soft tissue adjusting and whatnot, and then attribute all of their success to that one thing, and we as practitioners kind of build up like, oh, my manual therapy skills. You know what I mean? It kind of turns me off. So I don't really like that.
Yeah.
I think, with the loading aspect, you're giving patient independence. You're creating, you're telling the patient that they have an active role in their healthcare and solving their problem. And so, you're going to get better patient compliance, in my opinion, and they're going to refer more people to you.
Yeah, I think they. I mean, there's obviously some people who are not willing to do the work, but when they're willing to do the work, it's kind of like you were part of a team that did it, and it is very empowering to them, and they come back with questions, and they're usually pretty surprised by how something very simple could make a big change in them, and how they have control over their symptoms. Yep. So it's a big deal, and but yeah. All right, so
I agree.
So as we start to finish, then I know we talked. It was like 10 minutes ago we said that I'm going to let everyone know where to find more of your content. And so Cody's stuff specifically right now, he's exclusively on Pro Chiro Online CE. This is the only spot where you can ever learn anything about Cody, because he has not written his book yet, which he's talked about before, but still trying to find that personal time for after having a baby, huh?
Yeah, it's kind of tough, hard to come by. So
yeah, so the interns that I've shared all of your videos with the interns. I just think it's amazing. So everybody, please go over there and check it out. You do get CEs if you are a chiropractor, but honestly, it's not like, I don't even care about the CEs. Like I've gone to many courses so far, like Shacklock's course, and you don't get any C's, and you still burn a bunch of money.
How many courses? Yeah, how many courses I've taken and haven't gotten continuing education from it? It's crazy.
Yeah, we've had trainers already buy your course. They don't get any C for it. So.
Oh, nice.
Yeah, and so please, everyone, go over there and just check it out. Again, if you don't like it, you're not getting C's. Just tell us how to improve it. Like I haven't spoken to partners about any return policy, but for the most part, you go through there, you're not going to be disappointed. Like I would lay my hat on that. So, Pro Chiro Online CE, and Cody, leave people better than how you found them. And if you're dating an Eagle Scout, what do you got as an exit? Are you dating? I can find an Eagle Scout for you.
No. I have two loves right now: my wife and my daughter. So I'm good.
Okay. Well, we'll see y'all next time.
See y'all.